Okay, so the case should be planned very well. I will show one case that is integrated, and I'll show the full case here in order to maybe open or brainstorm your thinking. You may think maybe you have a plan better than mine. Maybe you can debate with me. Maybe you can improve my knowledge also. So let's go through this experience for this patient. The patient came and she was complaining of that her anterior upper teeth are progressively shorter and shorter. Like every time she see her teeth in the mirror, she see that anterior upper teeth are getting shorter, and she want to stop that. She don't like that. What happens? And she say, my smile now is different. And this is her occlusal or her dentition scenario. She had one crown on the upper arch, and this crown actually is not very nice. Ceramic chipped off already, and it's not very nice. But this is not priority. We are actually taking focus on the chief complaint first. She had a bridge, one bridge on the lower, and this is the radiograph for that bridge. The bridge is, as you can see, is very flat, very short. If you just see the crown is very short. So after occlusal analysis also, I found that her occlusion is reduced. Her vertical dimension is reduced. I found that many attrition points on the lower teeth, and the bridge also. Maybe the dentists for careful, sometimes they become over careful, they make the bridge out of occlusion, so that will also participate in making the forces on the other teeth. So at the end of the day, she will lose the vertical dimension, as she noticed also. And then she started to have the bite on the anterior teeth, so she started to lose the height of the anterior teeth. So what was decided is to actually that is her smile, that is her attrition. Unfortunately, I didn't take photos for her, or maybe I lost the photos. I don't know where are they, which is showing the deep bite. But I have the articulator. I have the jaw relation photo. That is the next slide. So actually, I took her jaw relation. She was biting like that. So that's why you can see the bite is only sitting on the anterior teeth, and she don't have the canine guidance because the malposition or the long axis of the left and right canines, unfortunately, was like that. So her canine is not really protecting the anterior teeth. So what happens? She's losing the vertical dimension of the teeth. So we decided to raise her bite. She also lost one crown. One of the crowns de-cemented and lost. She lost it. So it is the time to call for making a new crown also for her. But what happens? We have to raise the bite. So we took a Facebook transfer, move it to semi-adjustable articulator, and raise her bite according to the relationship that she recorded. And this is the crown that I mentioned to you, the upper crown. The ceramic already chipped off and it's not very matching in the shade, but I put it for her as an optional thing because it's not priority. There's no complication other than the aesthetic occlusally and maybe the shade. Anyway, so we decided to put for her crowns for this one. This is already crown prepared just to refine the margins and everything. So this should be crowned. Maybe some other dentists, maybe some other experts, they will go for occlusal veneer restoration, but I would say for safety, I will go for crown. It's already prepared too for crown. And then the others, which are the bridge area earlier, we decided to remove the bridge and then replace the missing tooth by implant. So that was the treatment steps and plan for her. We raise the bite for the patient by restoring the prepared tooth, whatever teeth, which is the crown to the bridge to abutments and the crown already there. So that's 3 crowns. And then we restore the non-vital, the non-vital whatever by crowns. And then we increase the vertical dimension for sound teeth by edelweiss because we don't want to cut. We just want to add. So maybe only etching and final touch-ups. And then we put the occlusal veneer that is just to raise the bite. So all the posterior teeth will participate in sharing the occlusal loads. That will be safety for her. Then she will have the space or clearance to restore the upper anterior teeth. So after this, restoring also 3/6, she helped to decide that she will make it as implant-supported crown. So that was good news. No need to put bridge anymore. And restore the normal size anterior teeth for the upper. And then after this, refine and improve the aesthetic for her lower anterior teeth. That is optional for her. Or maybe replace the upper crown, as I mentioned to you. That is also optional for her. So I started. This is the new bite that we established. And this is the new vertical dimension. So based on this relationship, we started to build. So occlusal, this is a vital tooth, healthy tooth, so that means edelweiss. This is already a crown prepared tooth, so that's normal crown, conventional crown. As you can see here, this is the plan for CAD-CAM. The yellow is the crown. So this will be occlusal VT, occlusal VT. So they will be participating as just to raise the bite. So that will be occlusal VT without invasiveness. Again, for the other side also, this will have occlusal VT. So there are 3 or 4 occlusal VTs and for 3 crowns. The 4th crown is already designed for safety to participate in the same occlusion before the loading by the implant or before the loading on the implant was done. So the plan is there. So once the implant is ready, then we just issue the crown over the implant, which is the same occlusion made by the same technician, made by the same CAD-CAM design. So that's for the safety. Okay, so the new occlusion is established. We cemented the crowns for her, and this is the occlusal, and the implant was placed. So that was you can see the edelweiss veneers, occlusal veneers placed on her posterior teeth. Those who are still intact and healthy. We didn't cut anything, so that was very good for her. We don't feel like regret that we cut a healthy tooth structure. As you can see here, the canines, they are out of the function because they are malpositioned. So this is the pre-operative, I would say operative for a facial veneer. This is the post-operative placement of the occlusal veneers and the crowns, including the implant. So this is when she came for the occlusal veneer, the facial veneers for the upper anterior teeth. So she had a stable bite, and we had 2020, the virus. She stopped almost a year. She couldn't come to the university. And by the way, I gave these crowns to the student because the objective of having such cases is to give confidence to students and also to be able to learn. So I gave these crowns to be placed by the student. One final year student, he placed these crowns. So then after this, she came with this occlusion, with this bite. The protected bite, I would say, is there already. There is a space at it, and this space will be suitable to be restored by edelweiss anterior veneers. Okay, so this is when we started. We had to put facial veneers, but there is a small diastema here. So I had to choose whether I choose different size, because when I check the trial here, I put the diastema is still there. When I match the size, this is a S size upper from the edelweiss. When I match the size, it was given the diastema again. So actually, as I told you, we are learning. I should give the option to the patient. Would you like to have a bigger size? M size maybe here, and the rest will be the S size. But she said okay, and the space was not very big, so I chose to make it as a composite, whatever composite filling that I'm going to do in the support. So it's just to manage, and it was okay. It was okay. The diastema, if it was bigger, then I would choose bigger size of veneer. Okay, so this is the trial. Actually, the trial, what as you saw with Dr. Jean, we just use composite. And as you can see here, this is the composite, a spot of composite, or maybe without, just to place it on the tooth to make sure that, to show the patient before we start. So this is not cemented, it's just stick. As you can see here, the margin is not adapted. I didn't cut anything. After this, we have to shape and shave the margin to make it thin as possible, and it will fit the margin there, super digital by 0.5 mm. And if the margin is really, like if you have different shade, you have to be careful, try to make it as close as possible, but within the limitation of the biological width. Okay, so this is the size guide. As you can see, it's matching very nice. It's very brilliant material. So you can see, and we chose based on this, the S size for her. And as you can see, the incisal edges also are restored by this. So I proceeded and I showed her the trial, and we decided the size and the shape. Okay, so we proceed with the retraction cord placement. Retraction cord is to protect the gingiva when we do the minimal preparation. Minimal preparation is actually needed for adaptation of the margin of the natural tooth to the margin of the veneer. We don't want to make any step for plaque and for any periodontal problems. So I placed for her the retraction cord, and that was the photo before I start the next procedure. This is the etching procedure, and then this is the preparation of the veneers and isolation. I just remember Dr. Jean when she was telling about the mylar strips. Maybe this is the non-expensive one, not the high-end one. I'm not sure, but we will go through and make sure that we will have the good one that is useful for the patient and can save time for us also. Because yeah, I noticed when I put, there are some spaces there after this. When I put two mylar strips here, it's double thickness. And I don't want to place and remove every time I want to put the bonding and then start to process one by one without doing too much changes for the patient. Anyway, so preparing the surface of the veneer itself as the protocol and placing the veneer bond. Here is the universal bond, but on the other side is the veneer bond. Because as we agree, this material is very much passive actually, because it's treated laser centered, or it's a glass material. So we have to put a special bonding agent. And I use this sticky stick as the Dr. Jean mentioned. It's very useful and safe not to drop the veneer out. So maybe you can consider in the overall cost. And I actually put some, this is not my first case, so I wanted to try a little bit more. I want to give some transparency appearance for the veneer. So I started to put as the videos and as instructions, and also as the material provided by Edelweiss, they have a veneer, they have a flowable composite that is yellow, bluish, and also the other one is grayish, and the other one is white. So you can put touch-ups and make it more aesthetic and more, let's say, natural looking. So I put this, and this is the veneer cemented in the patient's mouth. As you can see here, there's a gray line here that shows the transparency. Actually, it's just a blue spots, and I also tried to make the mamellans managing the same the protocol as I saw with Dr. Stefan. So this is after cementation, the buccal view left and right, and this is her smile for the restoration after it's done. So after she saw this, actually, she said, now I want to do my lower teeth as well, because I find that they are much better now in the upper teeth. So I want to do the lower teeth as well, although her smile line is actually low. So this is her smile eventually. And as I mentioned to you, this gap, she's already having a diastema, but it's now closed. But not closed in a way that it becomes like a different alignment of the teeth. So the patient is happy with this. So we decided not to do further, but maybe in the future, I would go for making options for the patient. So this is occlusal view for the restoration done in the patient's mouth. As you can see, the margins and the lingual surfaces are actually not violated because this is not going to be aesthetically compromising. So that will preserve the tooth structure. The only thing is the veneer going to act as the facial replacement, and it's serving for the patient purpose. So this is the post-operative. This is her smile. I asked her to smile as wide as possible. This is much as she can give until I stretch her lips, and then I asked her to stop, don't move her lips. So I got this biggest smile as possible. So I don't think she will make by herself this wide smile, and this tooth is not going to be visible. But as you can see, it's matching her face, it's matching her, it looks like aesthetic for her compared to the before. It was actually shorter, and she was worried about losing the tooth structure as well. And even I would say for lower teeth, for those who see her from distance, they don't notice, but she requested to have the lower teeth again. So I'm planning next very soon to start her lower teeth. And I will do correction also for the canines as long as they are malpositioned. So I took impression for her lower arch, and I want to do correction, I would say prosthodontic correction, not orthodontic correction, which we are going to cut selectively from the mesial surface of the canine itself, like this one you can see here close up, only mesial surface, and then we start to put the veneer. It looks like upright canine. It will look like upright canine when the root is still not upright. Same for this, so it will close the gap and make it much better. Same for the lateral as well. And as I noticed also, the canines are lower in height than the laterals, and laterals are lower in height than the centrals. So I will make them as possible uniform, so it will be improving the smile for the patient. Now, what are the challenges I faced, which I think whoever is teaching in university will have the same, and you will have maybe your other challenges if you are in a private practice. But we have to analyze, we have to understand our challenges so we can dissolve them slowly one by one in order to get the perfection. That's why I'm showing the limitations, not to give excuses for my shortcomings, because we are not perfect. So, but how can we overcome all our imperfections? By knowing and understanding what are the weak points and how to go through. So I would say we have very much limited time. We are committed first to teach the students and all the theory classes, all the clinics that is going to open soon. Also, we're going to open soon the clinic. So I will be most of the time with the students to teach them for regular basic things. Having like these extensive cases or maybe some advanced cases, it will be only limited when we have students coming and they finish their own requirement and they want to learn more. So because of the lockdown, also we had a lot of restrictions for the gadgets, also the PPE we put, and also for the procedures, um, who are coming, how many patients we can invite, and so on. And that delayed a lot the students' progression from like the final years last year and the fourth year the year before. And I would say I have limitation also. DSAs are not trained to take photos. I had to stop and take my photos myself. And although I try to convince now, I'm trying to convince one or two DSAs, I will show them how to take photos. I prepare the settings for them and just hold the camera and take photos, because it's very, very much taxing when you do any procedure. Your gloves are there, already contaminated with saliva, and then you have to put over gloves, snap one photo, not very ideal condition, and then come back again. It's really, really inconvenient. Students also, we have to train the students, and this is not in the curriculum. It should be something after they finish the requirement. That's why I had to start those cases when they finish the requirement and they want to learn more, something extra. Otherwise, we are breaking the chain. It should be like they learn the basic things because they are in the BDS program, and then only when they are in the final, at the end of the final year, and they find that they have not much to do, we start to get cases who are integrated for them so they can learn better. So this is the limitation. And this never happened in 2020. We were in lockdown and working from home. So that is also backlog, and I'm not sure about 2021. So this is my limitation, I would say. And yeah, I pick cases, those who have some part done by the students. I don't want to take case that I do all by myself because I'm committed to the students more. So I will do like this case. I give the crowns to the student, and maybe I allow them to do the straightforward veneers they did before. I had students who made the veneers. So they build the confidence, and when they go out, they can carry on. Whatever they learned in the chair side, it's going to be very valuable for them. They can practice and they can have it as treatment option in their practice, which is very helpful without this gap that I mentioned in the first slide. Also, I'm finding this experience as progressively improving my gadgets. What I mean, I started to buy the diffuser for the camera. I started to buy the contrasters for the photography, and even this Optradam, whatever, the retractor for the cheek and lips. Whatever we're buying actually slowly to improve the outcome, and that will be win-win situation. But this investment, of course, will take process, and we will learn. I didn't know many of the things. Last week only, I learned that the polishing system, the best polishing system from Dr. Claudio and the others. So conclusively, I would say, if proper selection of case, not every case, proper selection of case, and plan also is made, the Edelweiss veneer can be, or occlusal veneer also can be providing for you a very convenient and reasonable solution for a variety of cases and minimal invasiveness. You're not going to cut and feeling guilty for whatever you cut. You will feel much safe, and you'll feel much that you're doing the proper thing when you are actually using the hybrid solution, I would say. And then you will be saving time, because you don't have to, taking impression is really something, taking time, especially when you are in, like sometimes that you have to rush, there's a time limit in the clinical session, take impression, especially with the student also, and then send it to the lab. Now it's very difficult to send and receive. You have to worry about the infection control and so on. While when you can do the same thing here, you can restore the patient teeth in the same visit, just starting by like 2 or 3 hours, you can finish everything. Patient will walk out with a new aesthetic or new restoration. You will save costs, as I showed to you, and actually there is also another comparison made by Edelweiss in Europe. They have their own prices. So I tried to copy the same in Malaysian prices. I'm not sure about Philippines and Indonesia. I'm sure you can do the same. If you find it rewarding, although I tried to keep, and I'm keeping now, the price of Edelweiss always cheaper than the conventional crown, in a way that we can convince the patient, because patients, they have never heard about this, and they want to actually think about if they choose this one or not. So we kept it cheaper, always cheaper. But again, we're making more profit compared to the conventional crown, regardless of the shipping and sending out and in. Some carriers are already taking by the lab itself. So it's actually helpful not only for dentists, also for technician, because as you know that Dr. Stefan and Mr. Lampel, Mr. Martin, they are master technicians first before they start in this thing. So when they design this solution, actually you can have a help of your technician. You can, if you want to do indirectly, you can take impression, send to the technician. If you have in-house or you have to send to your own technician, they will do the preparation of the veneers before, and then you can get this veneer only for cementation in the patient's mouth. That will be also faster, especially when you have a case needs a lot of occlusal corrections, a lot of facial veneers, like 12 veneers. You cannot do it in straight one visit, of course, it's impossible. So what else? I would say the message as conclusion, there's no single magical solution. There's no ceramic single magical solution. There's no otherwise single magical solution. You have to think about how to make the best solution for the patient, preserving the healthy tooth structure and also replacing a safe replacement for whatever missing tooth structure. So I would say Edelweiss is a new treatment option you can add to fill the gap for your treatment for the patients that you have. Is not magical solution, of course, but it's very useful solution that I can add to my list and I can discuss with the patient and tell. So it can help me to make the best optimum solution for the patient. The technique is simple and accumulative. I will learn it slowly, and it will be very helpful. And it will be having a good specification as we agreed. As we saw now, we can also prove it and see it by experience. It will behave like a natural tooth structure. So it's not going to be destructive to the opposing teeth and adjacent teeth. And at the same time, is not, of course, resisting to accidents or maybe a very, very strong trauma or whatever. This is like, it's not exception, same like natural teeth. So of course, I will remind also, if you have occlusal surface of maybe a molar by a full metal crown, and you're going to bite this on veneer, on Edelweiss veneer, there is no exception that it could fracture if you are not doing the proper occlusion. And if you're not sharing the occlusion, if you make it a high spot, yeah, it can fracture, of course. This is not exception. So including zirconia, if you have zirconia crown biting on Edelweiss veneer, but you didn't adjust the occlusion, and occlusion is high spot on this, yes, you can fracture it. It's not a invincible material, of course. So that's why we have to think and plan properly. Everything will be running smoothly. However, we have also some advantages, I would say. We have a very, very unique supply and support system. I would say, I'm not generalizing, maybe in different countries is different, but in Malaysia, I'm really saluting the system. Like when I wanted to have refill of A3 nano hybrid, they came within hours, they gave it to me. And whatever I have question or something, they are very good in support. So this is an added value for the system, I would say, because very active suppliers and very active system there. Future development is also on the way that I came to know. They are planning to do custom-made veneers. So if you have a tooth that is really away from all the regular shade guides, and if you have long tooth with the root exposure you want to cover, you can in the future to do custom-made. And I'm a person who is really supporting the individualization for patients. So everyone has his own teeth. It's not like to copy other famous people teeth and so on. So I really support this idea of having custom-made veneers for the patient to give characteristics for the patient himself. They look natural, they save natural tooth structure, we're not cutting, and they behave like natural teeth, which are the surrounding teeth. So I feel this is a feature for this Edelweiss compared to the other compomiers and the other composite veneers, ready-made or maybe direct. Now, wide database available, so you can actually go through this website and I mean the WhatsApp group, and you can download many articles. It's not very new material. You can find articles, patents, and things, so you can get yourself really knowledgeable about this material and behavior. So you know the limitation and you know the also the boundaries. whatever, how much you can go for it, you can also know. And then you can share. This is a platform that I feel it's very active. You can share whatever you went through, whatever question in your mind with these experts. They will help you, and they will at least give you some safety when you ever want to decide and you want to discuss and troubleshoot also. And then you'll learn from mistakes. But of course, when you make the mistake, having knowledge and having some experience, they are not very big mistakes. So small mistakes that not everybody notice, but you notice yourself. So that is your self-evaluation will be very, very helpful for you for the accumulated knowledge, and you in the learning curve you can be perfect doing managing these cases, and also faster. So maybe first start case will be very slow. So having that, I'll give you example what I'm planning next. I'm planning to buy the best polishing kit advised by Dr. Claudio. As I told you last week, he posted this in WhatsApp group. He posted that you can buy. He's not biased to anyone. He's not actually giving one brand and say this is the best. He's giving options, but we don't have. We don't have inside. So we have basic things, basic systems, or maybe different because different market. But anyway, whatever I find, I would share in the WhatsApp group and ask those who have experience and those who already experienced. It will save time and money for me, and it will help me to decide. So I will start to target to find any of these systems and start to recruit, because it will help me to get the best outcome. As we know that this is a veneer made of basically composite and whatever glass. Glass also can have scratches. So if you customize and make the special shape for the patient, you need to polish it nicely, so it will be surviving and giving best outcome. I noticed that this patient that I showed, the gloss and the beautiful reflection of the light was not best. So I want to polish it for her in a follow-up visit. If I have this system, I will feel more confident. I want to buy also composite adaptation set. I have only the basic plastic instruments. So I will buy, and hopefully I have the support from the university to recruit such instruments that we can use, of course. And it's a learning curve, and it's a win-win situation, because once we have such instrument, it will help us to make better outcome. Same for this spot curing lens, I would say. We only have a full curing. So I noticed in the Edelweiss, they want to set or cure only one margin first, then they will refine the second margin. So that will be, we are not losing actually when we buy this, because it will be useful for many other options, not only for Edelweiss. It's something that is increasingly improving the service, and also following the contemporary materials. Established dental photography mini studio. I don't have, as you noticed, the background wasn't perfect. I wish to slowly get maybe a small studio with SOP, that anybody who wants to go to the studio will follow the steps and get beautiful documentation for the patient. And that is also one of the objectives that I want. I actually started to buy small, like the contraster, the cheek retractors, and so on. But then it will be, everything will be in that place that we call it as the mini studio, mini lab for photography. And then, yes, I started collaboration with Edelweiss, Saidi University, and Dental Academy. The Dental Academy, we have academy in Malaysia called the Dental Academy. They have beautiful platform for training. And we started communication to get a workshop when the lockdown is open. Of course, now we cannot. So hopefully we can start hands-on support from Edelweiss. They will bring the materials, and we can give the exposure. Whoever want to try the material, whoever want to do the simulation cases, we can do different levels, easy and moderate and difficult. So even those who have experience but they want to learn something more advanced, like changing the occlusion, like changing the alignment of teeth, managing orthodontic cases who don't want to go for any further invasiveness, yes, we can do simulation. We can take impression for these patients, and we can start. So actually, we will have all these. It will be very helpful, because when you start with this, you will have a very helpful boost or confidence to start